So welcome back. I wanted to give a little bit more information about our process at ICER as we were preparing this draft report. So Sarah Jane Reed, who is over here at the table, is our program director in Boston for the CPAC program, which I mentioned earlier. And she and I and other folks on the ICER team had a lot of opportunity to read published reports and talk to many national and regional experts about behavioral health integration. And one of the things that we clearly realized was that many people have thought about the various barriers to integration as well as some potential solutions. So we wanted to talk a little bit about that before we kick off the policy roundtable discussion. So this information is in the draft report and then also in the key tables and figures handout that you have. So we grouped the potential barriers into 5 categories, and different people think about this differently, but the 5 that we chose were reimbursement and payment. So the first thing that we heard a tremendous amount about was fee-for-service payments and the incentives that those create, and that incentives could be much more aligned under a capitation system with risk-adjusted capitation payments, as well as opportunities for shared savings and shared risk. So those were certainly key themes that came up as barriers. Cultural and historical influences, talked a little bit this morning about that, separate funding sources, different streams for mental health, substance use disorder, and physical health, as well as training and practice of those 3 different areas. And then also the issue of stigma still being associated with behavioral health. The third category was technology and information sharing, again, that this was tremendously important, but that there really wasn't as much uptake with the electronic health records as there could potentially be, or other ways of sharing information, and then also confidentiality requirements. The fourth area was around provider training and capacity. So most providers are not trained in areas other than the ones that they go to school for. So not surprisingly, they're not specialty in things other than what they were trained in, but so that creates some challenges, as well as a shortage of certain types of providers, particularly in California, having bilingual providers. And the last category was service capacity and delivery. So providers had said that they couldn't, there weren't many resources for them in the community to refer patients to, so it was difficult to feel good about referring people out. And then also challenges related to care transitions for people as they move between different types of delivery systems, particularly around Medi-Cal, if the functionality is classified as mild to moderate versus serious. Okay, so those are the barriers. There are a lot that you can see there. I just gave a few highlights, and then turning then to solutions that would potentially facilitate BHI in California. So a lot of work is being done at the state and county levels in this, as well as in the private and sectors. So at the state level, there's a mental health and substance use disorders work group that EFRAT is leading, and she can tell us a lot more about that. The state also just submitted a new waiver application, the 1115 waiver renewal, to the Centers for Medicare and Medicaid Services, looking at integrating care through increased use of electronic health records, cross-training of providers, developing service capacity, and then, again, changing payment in a variety of ways. There's also some opportunities at the state level with the Prop 63 funds. So counties were able to apply for innovation grants for various BHI projects. I just listed a couple here of different counties, Los Angeles and Sonoma, that involve multidisciplinary care teams and the provision of the 3 different types of services, also all behavioral health and physical health services in the same location. Some other potential solutions, a lot of discussion around reimbursement and payment. So adding in capitation payments, for example, for care management services or collaborative care that's provided in integrated settings, paying for site consults either done by phone or electronically, allowing for the same-day billing for physical and mental health services, and then reducing the restrictions on the types of providers who can bill for certain services. And an example that was given particularly was MFTs, so marriage and family therapists in California can't bill for Medi-Cal, but social workers can, I believe. Other potential solutions around improved screening, referral, and treatment processes, ensuring service adequacy for patients with complex conditions and really helping with care transitions, expanding telemedicine and providing team-based care with shared care plans, and then also improving consumer choice. So potentially using peer providers, which has been done for a long time in the substance use disorder treatment area, and then also providing culturally competent services. So that's just a kind of a brief summary from the many things that we reviewed, and we have a lot of folks on the policy roundtable and otherwise who have a lot of expertise in dealing both with the barriers and coming up with some innovative solutions. So turn it over to you, Jed, and look forward to a very interesting discussion.
Karen, thank you. And it may be, while Karen's review focused on California, it may be that folks from Washington or Colorado have some other policy ideas that might inform us in this state as well. So we have an opportunity now to extend the conversation we started, but more importantly, to get away from the dry evidence reviews and economic analyses to hear a little bit more about actual experiences of care, both receiving care and giving care. And for that, we've very thankful that Susan Plass has agreed to join us. She comes from a clinic that Kathan Volroth runs at Stanford. We'll hear a little bit more about that. But Susan, thank you very much for coming. And I think you have something to tell us about what it's like in so-called usual care and what you're experiencing now.
Well, let's start with usual care. And some of the things that presented themselves that made me decide to leave that model of care. I had a cardiologist who was amazing, but he retired. And in hindsight, he was providing my primary care. I went to see my primary care physician after he had left, and one of the early things they wanted to do in a physical exam was a pap smear, except that 3 or 4 years before that, I'd had a hysterectomy, and I didn't need a pap smear anymore. And so there were just things that weren't right. Essentially, my primary care doctor was a traffic cop. If I needed something, go see this specialist, go see that specialist. It would never have occurred to me to bring up a question of behavioral health. When I had issues about diet, especially when I needed to go gluten-free and how was I going to manage that and still control my weight, I found out that a nutritionist wasn't covered in my health plan. And so there was this whole raft of things that were silos, I think was the word I was hearing. And I managed over the period of time, say in the last 10 years before I switched, to gain and lose several hundred pounds, mostly getting it back consistently. When the opportunity was offered to me, because I have enough health issues that I qualify for Stanford Coordinated Care, to participate in it, I explored, and it looked like what I needed. I've now been participating in it just shy of 2 years, so I was following with interest that 2-year mark in terms of at which point does it become a cost benefit to the insurer, for example. But in that time, as I said in my bio, I had made, well, originally my goal was to be healthier at 60 than at 30, and then life intervened and my husband had major health issues and I couldn't deal with any of mine. So I switched my goal to, I was going to be healthier at 61 than 31, and I've made it. With the support of Dr. Volrath and the social worker through the clinic, I have managed to improve my A1C dramatically. My fasting glucose is down consistently below 100. I've dropped 80 pounds. I've dropped from a gene size 26 to a gene size 16 in 2 years. And my blood pressure medication is now cut in half. So for me, I'm a sample size of one, but boy, for me, that's evidence.
I think some of these primary care doctors would like to recruit you to their panels at this point in time. But I mean, aside from having access to a dietitian, what is it about Stanford Coordinated Care?
I have access to it. I would say that as I commented earlier, this is Cadillac care. I have access not just to a dietitian, but to a physical therapist. When I developed sciatica, I had immediate help to that, for that. I have access to a social worker who has helped me through the times when I've had some dietary relapse issues and needed somebody to not kick me in the pants, but to help me understand why I was relapsing and get back on the program. I have, I have access to a pharmacist who can help me figure out whether there is a medication that will work better for me than the one that's giving me side effects. And in addition, working with that, the social worker who is my therapist, my quality of life is dramatically improved because I've managed to deal with my fear of flying. I can now get on an airplane without having a panic attack. And we're now working on my fear of performance so that I we'll see what happens, be able to perform in my annual recital this year, again, without having a panic attack in the middle of it. That's what's different.
That's pretty different, and I think those are some outcomes that we'll ask Jeff to capture next time as well. So, Captain, how is it rendering care in this kind of environment versus what you'd experienced before, and what did you try? What was your systematic goal here?
Well, the setting I'm in now is sort of an extraordinary setting. I think you could call it an advanced primary care setting, so that it's a employer-sponsored clinics. It's for Stanford employees and their dependents, so it's paid for by Stanford on a capitated model. And what we are doing is trying to identify the top 5 to 10% of patients as far as healthcare spend in that employee population and offer them really advanced primary care with the hope of better care, improved patient satisfaction, and lower cost by keeping people out of the emergency room and keeping people out of the hospital. So as part of the two sort of key components of our model are supporting patients and their healthcare goals and developing motivation and helping support people and what's important to them, and team-based care. And what team-based care looks like to me is our team, sit in a room where we are elbow to elbow co-located. And so I work in, I think, what might be called sort of a bullpen setting with myself, our care coordinators and medical assistants, our behavioral health specialist, who in this case is a licensed clinical social worker with a lot of expertise in doing therapy, physical therapist, pharmacist, our clinical nurse specialist. So again, we're all in one room. We're talking all the time about patients. We share the same record. There are no barriers to me seeing notes. And I can ask questions, I can get advice, I can share information easily about patients. So that's the setting that we're working in. And I think another part of this is there's no copay to see me. There's no copay to see the social worker or the physical therapist or the dietitian. So the barriers for patients around those issues are intentionally low. And this is what you're seeing. There are more parts of the model, but as far as that's what the integration of behavioral health looks like to me.
And how do Stanford employees get into this Cadillac of healthcare delivery settings?
Well, we do. At first, we had to recruit, believe it or not, because it was new and because it was hard for patients to think about leaving their existing primary care doctors who they often had very good relationships with, although they had problems with the clinic and accessing care. It was hard for them. And there was sort of a sense of, this is too good to be true, sort of. So initially we had to recruit. Now we have to figure out how to select the patients that we can best serve, and we do that by having patients fill out a self-assessment questionnaire. So we are trying to select the top 5 to 10% of patients. And so the questions on that self-assessment questionnaire look like, how many specialists do you have? What's your self-reported health? How would you rate your health? What do you think is your risk of ending up in the emergency room in 6 months? How many medicines do you take? How confident do you feel in managing your own health? So we do that. So that's right now what we're doing to choose those patients.
So it's not administrative claims reviews and estimates, risk, stratification. It's patient reported with the universal survey of Stanford.
It's on our website, and so patients can find the survey and send it to us. A lot of work has been done on claims data and trying to identify those people, and we've been open now 3 years. We're still working through the barriers on getting insurers to be able to let us look at the information and getting those accurate risk assessments. So while we're waiting for that to be fully mature, we're relying on.
And my last question for you is, we asked Susan what it was like before, and before she encountered a traffic cop in her primary care setting. From the perspective of the physician rendering care, what was it like for you before in the other settings you've been in and now? Well,
the other setting that I was in for 18 years was I as a primary care physician for Santa Clara Valley Medical Center, which is the county hospital in San Jose. So a safety net setting, a Medi-Medi population. And in that setting, we were able to embed a psychiatrist in the busy primary care practice. So of the models that you've talked about, I have not directly experienced the collaborative care model. I've experienced what the co-location model, which is what I would call is working with the psychiatrist, and now I think I'm in the integrated care model. The reason that we did not do the collaborative care model at Valley is there was no way we could hire 40 RN case managers and 10 psychiatrists. We could barely swing one psychiatrist who supported 70 primary care physicians and probably 40,000 patients. By leveraging.
Good luck to the psychiatrist.
Yeah. Well, it did work, and it was the way it worked is she allowed us to be leveraged fully in our ability to take care of patients. As a primary care doctor in a safety net setting, you have to be able to take care of 70 to 80% of the patients coming to see you with anxiety and depression. That's just standard. Like, you have to be able to do that. And the question is, what can you offer for people, maybe the 20% of people with serious mental illness or refractory depression or complicated status? And for those patients, we were able to consult with our psychiatrist. And if she couldn't help us with a 10-minute consultation, we could get the patient seen for a diagnostic and medication evaluation, and she'd get them stabilized and send them back to us. So although it sounds, it worked. And it went from patients waiting up to 3 years to get a psychiatry appointment in the county mental health system to 3 months, which was hugely better, and then, to 6 weeks or so. So that was my experience before. with an embedded psychiatrist. I did not have access to a therapist. And now I have access to the therapist. And the thing that is important to me in the setting I work in, again with very complex patients, is that it's about the relationship. that we work as a team, we have a relationship with the patient. The thing I worry about with the collaborative care model is it does seem like a little bit more of a traffic cop approach. You're going to send off your patients with depression to the care manager who's managing them on a parallel track. And the message is going back and forth, or what the patient's experience is not necessarily something that you're going to be as well connected with as you want to be as a primary care doc. But again, I'm working now with the 5 to 10%, with a little bit different model.
So we'll get a little more feel for what the collaborative care environment is really like from some of our other panelists in a sec. Meg?
Oh, hello. I think I know you. Yes, I do. And I'm humbled. We're gonna get together after I need to chat with you. But I wanted to, my question is one that I think may be on the minds of many people here, which is, and you use the term Cadillac, and I think many of us think of, well, we know that this amazing model that you folks have put together and Dr. Glazarov have put together works. The challenge is really around the costs. I think the challenge we have is we say, well, if we all had those resources where you have, I'm not sure what your panel is. I know your visits can be quite long and wonderfully calm and less hectic and so on. You know that where I'm going with this. It's the question of how we as a society, or even any particular payer outside of Stanford, which can cost shift from some expenses and say this is barely dust in the budget compared to other things. How have you had a chance to think about how we take this wonderful model to the rest of the, I was going to say the world, but let's start even locally. I'm sure you've been thinking about that.
Well, under solutions, other potential solutions, we're talking increase in insurer service adequacy for patients with complex conditions. So that's the population I'm working with. So I where I came from. I came from the safety net, and that's where my heart is. And to me, this applies to a Medi-Medi population. They are that complex population that if you can put some of these services in the primary care setting, that you're going to save money with emergency room and hospital use, especially once we have a more accountable care, managed care population. So I don't think this is going to apply across, primary care in general, but if we're looking at targeting the most complex patients, I think that there's a value case for this.
Let's ask Meg's question to others, because we have folks from the state who are trying to encourage such a move. We have folks from Colorado who are actively involved in such replication and dissemination efforts. What do you think?
So I'll speak to Colorado, and then even more importantly, I'll let the folks from the state speak about California. But so Colorado recently won a CMMI State Innovation Grant. That's a multi-million-dollar grant that will be used to, in essence, transform the way primary care is delivered in Colorado. And it has a very ambitious goal of providing integrated behavioral health in the primary care setting for 80% of Coloradans in 3 years. And the reason why that goal is very ambitious is because there's a lot of future work that has occurred in Colorado previous to that CMMI award to put a lot of the infrastructure and do some, not all, of the some of the practice transformation, and also test new payment models in primary care settings. And by no means hear me saying that we've got it figured out or that we're there, because we're not. But I do think that the work that came before CMMI is going to be very, very beneficial. One of the things we've done as a potential solution is really taken innovative practices that have created their own models of integration. I think one of the things I absolutely wanted to say, and it's in the report, is that there is no one model that you can prescribe to a community or to a practice and expect that it's going to work. This is not a one model fits all sort of deal. So there's various different integration models that have been tested in Colorado, and the transformation of what it takes to do that in practice, the collection of the data to actually see if it has effective clinical outcomes, and also the types of changes in payment that need to go along in parallel as that transformation is happening, are all of the things that are being tested in Colorado right now. That's been our solution, one of the pieces of our solution to this large transformative effort that we aim to undertake.
80%, I hear. Dan?
Question, at least my understanding is that there is a shortage of primary care doctors, that the kids coming out of medical school today don't want to go into primary care. They want to be dermatologists or whatever. So now we're piling on an additional burden that is the behavioral health care. So my question is, does this actually make them more efficient? In other words, are you taking some of the burden of primary care and helping them with it, or are you just thrusting more responsibility on an already beleaguered primary care doctor?
I'd love to respond to that because, well, it's a great question. And the primary care providers that I work with in San Diego ask that all the time. Their initial response is, so you're going to make me do what now? On top of the 14 other things I have to do in 15 minutes. And while it may be true that they may need to look at a PHQ-9 that the patient scored, the vast majority of what we're trying to do is take the burden off of them. Most of the docs that I work with didn't go to medical school to be behavioral health people, and most of them are happy to give that patient up through a warm handoff to one of the behavioral health people that I do work with. So, and I try to sell it that way because I really believe we are trying to take the burden off of them. And there is evidence, I'm sure Dr. Wells and John both know, showing increased provider satisfaction for PCPs when they're working in this model. So it's really, like you said, we're really focusing on trying to take the burden off of them.
Yeah,
Marty?
I agree with that. I think it's not so much about doing more work as it is about doing it differently. And I think that's where the training programs are really important, and not training in silos, so that the new primary care doctor knows how to work in a team-based approach with the behavioral health clinician and vice versa.
And as a primary care doctor, 50 to 60% of my work and my visits is behavioral health. So that there's no way
To get around
to get around it. That's bread and butter primary care. And as with other problems, one of my roles is to diagnose, to recognize it. If I don't diagnose it and recognize it, it's still there. It's just not being treated and not being addressed, and we're not making progress. The same as if I didn't diagnose rheumatoid arthritis or another problem so my role is to diagnose and to figure out a treatment plan and get people to the right level. And as a primary care doctor, what I'm really looking for is that right level, those resources. There are some things I can take care of. I can prescribe the antidepressant, but there are some patients who need more, and I just want to be able to get them to the right level of care, and often that's not available.
Doug?
Well, I just want to ask a clarifying question. I'm also a primary care doctor. So we just heard this really eloquent discussion about a woman who had a cardiologist who really served all those needs for many, many years, maybe decades, I don't know. But I'm interested in what's the patient perspective. Would they rather actually have their care partitioned among multiple providers as opposed to having a primary care doctor that actually had perhaps better training and more time to actually deal with these problems themselves?
I have to say I always felt guilty spending the extra time that my cardiologist did with me, because I knew he wasn't supposed to be, but he was going through my diet. he was going through what are the right meds, and we went through every statin currently invented before I gave up and I couldn't deal with the side effects on any of them. He was spending way more time with me on things that should have been handled at the primary care level. I was referred to him because I had an eye embolism that was threatening to make me blind. I mean, there were good reasons that I ended up at a cardiologist, but I shouldn't have stayed there for what was basically primary care.
My point was, it sounds like that worked very well for you, and the question is there are other models where someone like your cardiologist, who's actually a primary care doctor, could have served that role.
Oh.
And it sounds like, unfortunately, when you sort of shifted from the old school primary care, if I can use that, to sort of the new school, which is where we have 12 minutes to see patients and a lot of administrative responsibilities and charting responsibilities on the top, that type of a relationship is almost impossible. So that was my question. It's not so much the individuals involved, but whether you would prefer actually to have had someone like your cardiologist who actually was a primary care doctor but had more time
Yes.
and resources.
I think that's what I have now. I have someone who can handle the problems and will refer me when she really feels I need a specialist. But I have the relationship with my primary care doctor that I didn't have at my previous clinic.
We're getting into it now. A lot of people want to speak. I'm going to ask Efrat to talk a little bit about how the state is trying to pursue this. Is your scope of your change to get 80% of practices in California transformed? Marty, I'm going to ask you how close you are to that goal in San Diego County, and then we have lots of other people who want to ask questions.
Before that, I just want to say something about the primary care. You know what we're talking now. We were implementing SBIR, the alcohol screening brief intervention and referral to treatment in California since January 2014. And one of the things that the state decided to do is to provide with training to the PCPs and the people in the clinics, so that really to help them deal with the patients that they will have to deal now. And what I just wanted to say is that I don't think that the PCP is supposed to deal with all issues that are related to alcohol abuse, but they can do something. They can do the brief intervention and maybe help. You know, it's a tool, or it's a way to really engage with a patient, so that we can refer them in a effective way to the right treatment. So I don't know if everything needs to be treated with a primary care, but I think that primary care physicians or clinics, and it doesn't have to be the physician who is doing it, because we are encouraging other type of providers to come and provide these services in the clinic. To do that, and then what I see, maybe the change in the primary care world is that it's really more accepting and can deal with patients that before they dealt very poorly.
Okay, Marty, just how many practices are taking this up in San Diego?
Well, I've been working with the FQHCs on behavioral health integration for about 7.5 years. And in the first 6 years we did it, one of the things that I kept track of was the number of behavioral health clinicians that were working at the FQHCs I work with, and there had been in 6 years a threefold increase in the number of behavioral health clinicians. That includes psychiatrists and therapist types. So we're seeing a change at this. By the same token, it's nowhere near 80%. We still have a long ways to go, but I really am kind of taking a long-term kind of social change perspective in this whole thing, because we have primary care docs who were on board day one, the early adopters, and then the folks at this point who are now saying, well, I guess it's where the train's going, I better get on it or I'm going to be left behind. And then we have some docs who I just hope will eventually retire, because they're never going to get on the train.
They probably hope so too. So.
Yeah, feeling may be mutual. But so it really is kind of a long-term perspective. So, we don't have goals nearly as ambitious. By the same token, we're getting slow and steady progress.
That's great. Ken, you had a comment, and then Jeff has a question.
Yeah, I thought I would mention what Los Angeles County in the public sector is now doing is something called Health Neighborhood Initiative. And that is to coordinate the mental health, primary care, and substance abuse services for shared behavioral health clients, because many of them are shared across those sectors, while addressing local priorities for social determinants of mental health, whether it's violence or incarceration or social isolation in the elderly and so forth. And that came about, I don't know if you can see this, if you don't mind, I will show a picture, but you'll get the idea. Can you see that map, that Google map? See that? Google map. So this corner is a homeless person, and this is where this individual is getting their primary care services and their social services here at the beach. There's actually social services and mental health right across the street. But when this individual is asked, why are you going 85 miles by bus in no traffic, which doesn't exist in LA, for your social services, it's because I swear I feel respected, as a homeless individual. Now, so we asked 1,000 depressed people, every single place they've been trying to get help for depression in the last 6 months. There were 20,000 attempts by those 1,000 people to get depression. 65% of them were not in any kind of healthcare specialty or substance abuse setting, but they were in the barbershop, or they were in the senior center while they were exercising, or something like that. And that's, in a sense, what you see here. So the doctor is spending their 12 minutes with the person. The rest of their life, they're trying to get help for their problem from all kinds of people. What are they hearing? What are they saying? And how do you bring together that? In my view, that's the broader challenge. And I realize it's very important to get primary care right, because people trust their primary care provider typically in a way that maybe their minister and their primary care provider. But this is the coordination challenge. And I'm almost done with getting off the...
Go ahead and sit down so I can hear it.
All right. And this is why we move towards a community integration model. So how do you get the minister and the primary care doctor and the mental health clinic understanding, what needs to be reinforced to move forward? Then less does fall on the primary care doctor. Although we do find people then turn more to their primary care doctor as well as their minister, as well as their exercise person who's been trained, so that support broadens. I also just want to mention, because the issue came up, that many minority clients, and many studies have shown this, actually have a preference for psychotherapy over medication for problems like depression, and they're roughly equally effective in problems like depression. So the challenge, when all the primary care provider can do because of their infrastructure is to do medication, is that some people just will not pick up on treatment. And we actually did a study. The paper is called "Ethical Outcomes of Quality Improvement for Depression," and we found that these approaches to collaborative care actually improve the chances that people will get the treatment they prefer. Right? It might be medication, then they're fine with their primary care doctor. It might be therapy, then it's available from the care manager, or the primary care doctor has that relationship like you do in your practice with the therapist, and that person can get routed there. So from a patient-centered care perspective, there's also that added value. And I'll just say one other thing, if I may. So patients with depression in the safety net, they don't just have depression, and they don't just have health problems. They have poverty. They may be nearly homeless. They might have prisoner reentry issues and all of this kind of stuff. And their priorities actually might not be to treat their depression. It might be to save their child being in their home, right? So the collaboration interventions that we need, especially around Medicaid patients and in safety nets and FQHCs, are really to help patients get what they need and want. They can't do everything at once. That moves them forward and helps their life overall. That's, if you will, the new challenge beyond collaborative care, is really integrated thinking about the patient's needs, the role of the doctor, and how we all have a role in this society in helping our most vulnerable move forward.
Maribel has one comment, and then I'm going to ask Susan if she availed herself or was referred outside of Stanford Medical Center per se to community resources and other things, and then we'll get to Jeff's question. So Maribel.
Brief comment. That was beautifully said, and we couldn't agree more. Clearly, Colorado believes in integrated care in the primary care setting, and we're going to be doing CMMI to get that piece rolling. In parallel, we really want to focus on community-based interventions and specifically looking at contributing to the field of the prevention of mental health issues and early intervention for children and adolescents. We really believe that absolutely is the next frontier. And while there are interventions that could be helpful within the primary care setting for screening for trauma, for example, and providing trauma-informed care, many of the answers are not in the four walls of the primary care office. Many of the answers and the right interventions are absolutely in the community.
So just quick response, community?
Do you mean before or after?
Your experience all along.
My experience before was typically if the clinic I was part of didn't offer a service, they would refer me to somebody, which would be paid out of network, and I'd have to deal with that. Currently, I've been referred mostly to specialists when needed, but the one that is most applicable to this conversation, there is an organization whose name, of course, I can't remember in Palo Alto that deals with issues of blindness. And given that my primary medical problem is repeated occlusions of the retina, so that little by little my sight's being chipped away, I was referred to them to get some idea of what kinds of resources would be available and what kinds of resources I might use to prepare for what might happen.
Thank you. Jeff, your question.
So it's a little bit of a change, but I've been wondering about this after hearing these conversations. And in the preparation for this discussion, which is very complicated about what exactly the different components of this integrated collaborative care model are, there's a lot of discussion about, well, what is the secret sauce? What's the thing that makes the difference? You've got lots of different components, and what is it that's the key thing? Because if you're going to implement, you'll want to know what to implement, and people are always looking at, is there a, we had this discussion, is there a more cost-effective way? And so what I'm kind of hearing, and I'm wondering if you would respond to this, is the key to this that you're doing systematic screening, organized population management for mental health problems that doesn't rely on the primary care doctor to do all the work themselves? Is that sort of the core to this? And if that is the core, in other words, you're doing population management, not for diabetes, but for, mental health problems. And if so, if that's sort of the core, then the question I would ask is, who needs to do the work of being the care coordinator, and what are your marks that you have to track? Because that might be kind of the skeleton as opposed to hiring a bunch of RNs or specific, this FTE for that. Is that kind of the key to this, and is that the thing? Because, boy, I tell you, if I was a primary care provider, anybody that helps me do my work is going to be a friend of mine.
Let's just go right down the row. I suspect everybody has some view into the secret sauce in Jeff's question.
So the key is definitely a physician extender to take on most of these tasks. You can't just ask the primary care provider to do more. Which is why I said before, you do need probably to do new hires. It has to, it's part of the secret sauce. It's got lots of different flavors in there. Measurement-based care is key. So screening, but screening alone is not enough. You have to then track their outcomes over time. What happens in usual depression care is a patient gets sent to psychotherapy that's not effective or given a medication that's not effective, and then their treatment never changes. They just keep going to psychotherapy, they keep taking the same medication, and no one's ever seeing whether it's working. And doing serial PHQ-9s and saying, okay, it's been 8 weeks on this medication, you haven't improved, we need to make a change, and stopping that clinical inertia. And it's frustrating to primary care providers if you just say, hey, the patient's PHQ-9 score is not better. So you have to have a psychiatrist who can review the case and make a treatment recommendation to the primary care provider along with that bad news that their patient is not getting better. I think those are the key things. And one more thing, that a lot of the integrated care models don't reach out to patients that aren't showing up in the primary care clinic. You've got to have a registry that says, okay, here's all the patients I'm following, and if they're not coming to the clinic, you need to track them down and find them where they are. And that is absolutely key.
I'm not sure that I know the secret sauce, but I can share a little bit, with the question that you asked me before, what the state is doing or what its plans to do. And regarding to these issues, I think that what we thought, based on a lot of stakeholders meeting that we had around the 1115 waiver renewal, we were meeting on different issues. In each one of the issues that we were discussing, like workforce, etc., we had a mental health and substance use experts in these meetings. And one of the things that we were thinking, and that I think is an ingredient, is using community health workers, using peer providers. That's one thing that we are trying to convince CMS that could be very helpful. Also sharing, but this is maybe a little bit out of the scope here, but sharing the risk between the mental health and the physical health plans, and between providers, so that the providers will have a stake in really providing coordinated care. So these are the things that we are thinking. There are many more things, but I know that you should move it forward. And another piece is really telecom and having psychiatrists or psychiatrists and other clinicians talking to providers and others in other cases, especially in counties that are not San Diego or others that are in the middle, and have enough psychiatrists, etc., to really have psychiatrists that really telecommunication with patients as well.
That's great. And let's try to keep track of these elements, because we're going to go all the way down and then ask Neha, who I've not forgotten about, what commercial insurers are doing to support all these elements in the transformation of primary care. Marty?
So we, about 7.5 years ago, implemented the impact model and trained everybody on the model. And John sort of touched on some of the components, but I try to keep things simple so that I can actually train people. The model to me has 5 basic components, and so this kind of gets to what you were mentioning, Dr. Klingman. You have a depression care manager. They call it a depression care manager, a clinician who's really the glue. What we've been talking about is the glue. Consulting psychiatrist, which John recommended. It's a collaborative care model, meaning that everybody's invested, as Efrat's saying, in this particular model and communicating back and forth, which the depression care manager is sort of in charge of making sure happens, but everybody's invested in that.
Typical care manager is what?
Well, in the original study, they used RNs, but we, in fact, in San Diego are using master's level staff. These are not licensed people in most cases. These are people going to graduate school to become licensed mental health clinicians. And we happen to have a plethora of those folks in San Diego, so they're very convenient and very good at this particular thing. The other thing that I should mention when I'm talking about staffing is not everybody's built for this kind of stuff. The primary care is fast-paced, and a lot of the people who went to school like I did thought they were going to be a psychologist for depressed women living in La Jolla, neurotic women living in La Jolla, and want a water feature and a nice quiet office and don't want to be interrupted, and that's not primary care. But there are folks who do really well in that fast-paced, exciting, you don't know what's coming next kind of environment, and those are the folks you want. And so it really doesn't matter as much what degree. It really kind of, you want people with certain characteristics. They kind of thrive on an exciting environment. They thrive on not knowing what's coming next. They're able to work quickly. They're able to communicate in 2 sentences with a primary care provider about what's going on in these sort of curbside consults that happen in the hallways, because we stick their offices right there amongst the exam rooms. That's what I envision as collaborative care. And then John mentioned outcomes as well. We'd like to do a PHQ-9 or a GAD-7 or something at every session, so we're tracking how people are doing. And then when they're not doing well, you mentioned the stepped care, which is kind of the 5th piece of the whole thing. When they aren't showing improvement over a certain period of time, we step up the care to something different.
I want to capture all the answers to Jeff's question because it came up so frequently this morning. Maribel, any thoughts?
So I'm looking back at my list, what hasn't been said yet. And actually, before I tell you what's left on my list, I want to invite you to read our journal supplement about the secret sauce from what we have learned from an initiative in Colorado called Advancing Care Together, which followed 11 innovative practices basically for the last 3.5 years doing this work. And it was an observational study that used very rigorous mixed methodology. And all along, we were very, very interested in what does it take to really implement this and really dissect these elements and understand them better. So all of the secret sauce will be revealed in this journal supplement that will be published in September of this year. But of the things that are still on my list, I want to talk about just very briefly about leadership, critical to be able to do a change of this magnitude. The complexity in doing this work on the ground is unbelievable. And when you really get in there and you start observing it and seeing it, you understand not only the complexity of transforming a practice to do behavioral health integration, but the complexity of the need that people come in with and what you have to do in order to meet that need. So having a leader that can inspire, that can speak a clear vision, that can make sure that everybody working in the practice has a shared mental model for what's happening, that can thrive with resistance, that can create partnerships in the community. You need an exceptional leader, really, on the ground in order to do this work. So that's one thing. The other thing is, it's been alluded to already, physical space that facilitates collaboration. And that doesn't necessarily mean build a clinic from the ground up if that's just not, what you have resources to do. It may just mean reconfigure what you have, get creative about putting people close enough to where there's bumpability. It's what we call it, so that they're in each other's faces basically all the time, so that communication and that collaboration can take place. Another one is making sure that you invest in continuous training and an onboarding program for everybody that's going to be working within this model. Training is going to be critical, and it's not so much the credentials, it's more the fit, as you had said, but also whatever training is necessary to make sure that somebody who's coming potentially from a more traditional mental health setting can be trained to deliver a brief intervention, to communicate in a way that's going to be feasible in a primary care setting, who can do motivational interviewing, all of those things. And then make sure that you have somebody that's really good in your practice that understands workflow and that knows how to change workflow and map workflow and can do it continuously all the time as practices tweak different things to figure out what's actually going to work for that specific setting. I'll stop there.
Great. Ken, you've been waiting?
I agree with everything that's been said. I think under, sort of the classical model, all of these things, the meta-analyses have suggested that care management is kind of the single most important thing. I sort of would like to just comment on one thing that hasn't been mentioned, which is community engagement and co-ownership. I think in dealing with under-resourced, especially communities of color, it's very important to engage not just the providers, who often themselves may also be minority providers, but the patients and the families, if one is going to be successful because of the stigma and other issues, and to do this with some equity. So, and in fact, the trial that I alluded to that we've published recently, we compared more technical assistance and community outreach to do collaborative care with an approach bringing people together with co-ownership, redoing it to fit the culture of the community. And it was that model, over and above the more technical assistance model, that led to the improvements in homelessness and reduction in hospitalizations and other things that I referred to. So I think in the safety net context, community engagement and co-ownership, I would add to the list.
Kathleen, any other thoughts based on what you've been hearing from your colleagues?
I guess one thing is something that I would say don't do, which is don't screen for things that you can't take care of. If you're going to screen for depression or substance use disorders, you have to make sure that you have the resources in place to follow up on those things. Nothing's worse, I think, for the patient or the primary care doctor to find these things and not have the resources to deal with them. So they have to be in place. And that doesn't necessarily mean they have to see a clinician or they have to have medication or psychotherapy, but some people don't want either of those things, but that those resources in the community are available, resources in your clinic are available to deal with all the problems that you're going to turn up, and that resources for very ill people that you turn up are available.
So do you do a universal screening for depression and anxiety in all of your patients?
Yes, as part of the intake at Stanford Coordinated Care, we do several assessments. So we do the PHQ-2. We ask the 2 questions, and then if that's positive, then everybody gets a PHQ-9. So that's what we do. We also do, which is I think very useful, a patient activation measure, the PAM measure, and putting those 2 pieces together. Those can be really helpful. And then my experience of the secret sauce is the relationship. As a primary care doc with that care manager, the relationship with them, that they know me, I know them, we know how we work, that's really important, and that person really knows the patient, and they know what's important to the patient. Telephonic care management can be disappointing when it doesn't really, when there isn't the relationship with the patient.
Very important. Susan, I'll just ask you how all these secret sauces taste, and then we'll ask Neha for her perspectives.
Well, actually, Dr. Vollrath capsulized what I would have added to this stew, and that is its relationship, which means that the people involved need to be given enough time to develop that relationship, which means you can't do it in 12 minutes once a year. So I don't know where the funds, where the resources come to provide that, but that's, I think, the secret sauce.
Well, a lot of them come from Anthem. So, Neha, you have a most interesting title, Manager Community Transformation. Could you say a bit about your vision, your work, and how it intersects with what we've heard today?
So one of the things about me is that I'm actually a licensed professional counselor. So I've spent a majority of my career in the mental health world, working anywhere from residential, outpatient, doing case management at Anthem for behavioral health. And then recently I moved over to transformation. So I've been feverishly taking notes. And so what we do as the Enhanced Personal Health Care Program is we have our pay for performance. So we're paying for this. We're paying for the transformation work. So we have a shared savings component. And I got started into this field because, one, it was interesting, and it was just a kind of a lovely bridge between my behavioral health background, and then I had recently got a master's in business. And so I was like, oh, how do I combine the two? And this was a perfect opportunity. So when we launched our Enhanced Personal Health Care Program in 2003, with the pay for performance, behavioral health wasn't really a major part of it. It was still the background, wasn't really part of it. It was more about, we're giving you data, we're giving you some funds, how do we help you manage your patients better in the primary care setting? So our goal, so I'm in Colorado as well, but I also manage West Region, so I also manage California, was to get 100% of our primary care providers into this program. So we're at about 55% right now. And so I keep looking at Maribel because they invited me to attend the ACT Innovators meeting, and I feverishly took notes about what's working, what's not working. And one of the things that we have done over the last year or so is put together a program to really support behavioral health integration. So with all of those notes and the secret sauce, one of the things that I'd like to add to the secret sauce is build your infrastructure first before you implement. Because one of the things that I have seen happen so often is, well, they say we have to do the PHQ-2 and the PHQ-9, let's go ahead and do it. But they haven't set up what are the resources, what's in my medical neighborhood, can I build, I know a ton of practices across the country who are doing this work and not billing for it because they don't realize they can. And I'm like, really? You're doing free work, which is great because it comes from a good place, because you want to do the right thing, but we want to also make sure that you do the right thing and are also going to get paid for it because it's important work and it's valuable work. So part of the program that I'm launching, we're doing a pilot project within Anthem across our 14 markets, and I'm starting with 3 little practices because it's just me and my manager who are still launching this project. So we're doing a pilot project with 3 primary care practices, regardless of their size, who have a leadership commitment, who want to be part of this pilot where they're going to be committed to working with us and really have that vision, which was also part of that secret sauce, that they are going to do this work, that they're going to build that infrastructure. And we're going to help them by giving us the support. So one of the other parts of our program is not only do we give data, we give the financial support with the shared savings and pay for performance, but we also give you feet on the ground support. So we have 2 or 3 people, individuals, who will come to your practice and support you in this process, whether it's virtually or face-to-face, to do the work, to use the data, to understand our data, and figure out how you build that infrastructure. So I've created a checklist with all of these secret sauce items in there, and the very first one is leadership commitment, and the second one is training, that you can't get to actual implementation till you do those pieces first. So my hope is to continue this work and hopefully collect data, observational as well as claims-based data, to really see if this is going to work. And based on what we were talking about today, some of the notes that I made myself is really to look at the difference between a patient-centered medical home, who's a level 3, for example, NCQA recognized, if they do this project versus another practice who's not, or not a similar recognition, because we know that PCMH is not the only one. And the ones that are truly level 3 and are actually implementing and actually following through and not just checked off the boxes on the application form to achieve their level 3, what difference does that make in terms of the cost for the infrastructure, the implementation, and the maintenance, and does it make an impact on that patient population? And my goal is to try to, put it into practice and then develop the outcomes for the next, hopefully 2 to 3 years, and really see what the progress is, because I think it really takes that long. So hopefully I'm around for that long. Hopefully the project is still funded for that long, and I'm looking for a practice in California.
There we have an open offer from Anthem. And it's not only Anthem. I mean, Karen collected a number of resources that show that other insurers are willing to provide monies for training programs and on-site implementation support and the rest. Bob?
Regarding the implementation of the impact model in San Diego, La Jolla, sorry. One of our self-imposed duties is to come up with options/recommendations for policymakers and insurers, although it sounds like Anthem's doing fine, thank you. You just made the process a bit more difficult because there's not a line diagram that can be stated to be the way to go. There's not one size fits all. And it seems to me a lot depends on the care manager and the right personality, willingness to engage in the sturm and drang of the clinic. And my question to you is, how do you screen these people? I mean, you surely can't just hire people and then fire them if they don't work out. I mean, you can, but that's grossly inefficient. How do you screen them? What are you looking for? Because it's already been stated that it's not the degree per se, it's the person's personality and commitment. How do you screen?
Yeah, it's a great question. And I wish I could just tell you exactly what I do, except that they actually work for the FQHCs. And so the FQHCs actually hire the folks, and then I get to train them, which means that there's even more likelihood that in our particular case, we could mishire. But I think the FQHCs have a pretty good idea when they bring these people on what is going to work in an FQHC versus, say, a mental health clinic. One of the things I would look for in a background of somebody is some experience in an inpatient unit or a crisis residential unit, someplace that's going to be fast-paced and kind of like primary care, kind of a lot going on and a lot coming at them, and you can make a plan in the morning and 15 minutes later that plan's out the window because something else happened. But I don't actually hire these folks, and there are cases where I've had to go back to the leadership at the clinic and say, I don't think this person's going to make it in our particular instance. They want to do 50-minute, sessions in a private office. They're not willing to be interrupted. But by and large, most people, by the time they get through the hiring process at the FQHC, know what they're getting into. So I don't have as much trouble as you might think. Great question, though.
Alex?
I'd just like to hear from some of the panelists about how much of a barrier this rule that FQHCs can't be reimbursed for primary care and mental health services in the same day is.
Huge. I wouldn't have a job if that did not exist. Integration would just happen. Seriously, I mean, they would just do it because they want to anyway, and it now would make not only financial sense, but ethical or whatever sense as well. So it would just happen. The other big barrier nowadays with all the new, while I'm on this soapbox right next to the person from the state who's going to hate me in just a minute, if she doesn't already. The other big thing we need to do, along with getting same-day billing, the same-day billing issue taken care of, is get MFTs to be billable, at least in California, in an FQAC, because we now have, with all these new folks with Medi-Cal, we now have even more people with need, and basically, the same provider base we've always had, and a group of providers who are at the ready, the MFTs. If we would simply just let them, we could at least make a dent in the new level of need we've got. So. All right, I'll get off the soapbox now.
Okay, Jerry, and then Chris.
Yeah, we may just have gotten the answer, but Alex's question opened the way. Those of you who work in California, and especially since we're talking about the Medi-Cal population, what other changes in policy, because we'd like to talk about policy implications, would you recommend? We've just heard two, if I was listening to you correctly. Are there others that leap to mind that ought to be addressed as a priority?
I'm answered two issues with the same question. Paying for virtual care really needs to happen. I actually don't agree that the bumpability and is important. If you look at this table on key tables and figures on that show that the collaborative care models where there was an off-site support and telephonic support are just as effective as those where everything was done in the practice. And we actually did a trial where we compared on-site practice-based care to off-site practice-based care. And the off-site did better because they had more expertise. So it's not so much where people are located and how they're communicating, and we have to pay for virtual communications. Like a psychiatrist talking to a primary care provider, that via electronic health record progress note. That would be nice if they could get reimbursed or something like that.
That brings up an issue about communication of confidential and substance abuse and mental health information. Can we spend a second on that, Jerry, and then we'll collect some other ideas for policy changes? We can call it hippity-doo-dah.
EHR specifically, not so much about the piece you were talking about, but the report says, EHRs have been widely adopted for the most part in primary care settings, not so much in behavioral health settings, and that is true, of course, and it is a limitation. However, what we have found is that EHRs are very poorly designed to do integration. So that's yet another issue to where there might be policy implications as well. And frankly, to just do comprehensive primary care in general. EHRs have very poor registry functionality, an inability to track data longitudinally, to help people communicate, back and forth, to have collaborative discussions, especially if they're not bumpable and in the same physical space. And for some reason, we're okay with that. EHR vendors, I think a lot of times, feel that they don't really have to do anything about that, and it's not okay.
I just wanted to say on the topic of EHRs, where I am, working in this really lovely integrated system, one threat that came up to that was the edict that was going to come down from the social work department that our therapist, our social worker, had to document on a template. Before, I was getting lovely paragraph summaries with her assessment, her synthesis of the information that I could read and get a sense of. And then the edict came down that she had to do intakes on a template. And many of you may be familiar with what a template looks like. It's incomprehensible, and certainly not something I want to look at as a primary care doc. So I think we were able to avoid that. So far we've avoided it, but just a caution about that is.
And with respect to the confidentiality of mental health, you said you communicate quite freely. Were there any problems trying to make that happen? So, one, we sit next to each other, so that helps. But she writes her notes. We have Epic at Stanford. I see those notes. There's no problem there. The big barrier for me would be if a patient is getting mental health services outside of the clinic, perhaps with a private psychiatrist or with a private therapist. I've never seen one of those notes. So the barriers to that of faxing back and forth, the appropriate documentation are quite high. But within the setting I'm in, there is no barrier to that.
Yeah, the whole idea of information sharing is another box that I want to get up on, I guess. What bothers me about the way that we've kind of set up these barriers as far as being able to pass information around is in some senses as clinician, we've perpetuated the stigma that this information is somehow special or even worse, shameful, and shouldn't be shared. And so I feel like those barriers need to come down so that, we talk about, removing the stigma. Well, that's kind of a stigma builder in my mind. So that's kind of what I tell everybody when they start complaining about, sharing information. I shame them into doing it, I guess.
Ken?
Two comments. One is then one needs to move towards patient consent for sharing that information. That's what move towards patient consent for shared information, which is what we're doing in LA County. The other thing is, I thought I would just, and John, I don't know if you would agree with these points, but just point out some issues with practices and insurance companies evaluating these innovations. So typically what happens is, as you mentioned, a fairly high bar is set for a practice for good reason. You want to make sure it's a successful implementation. But then what's going to happen is you may have a practice that's already giving better behavioral health care, and it can be harder to show improvement. And even when you've succeeded, suddenly it looks like, well, care is going down, or, because you've selected at a time. So I'm just bringing that up as a note. The other thing is there's this sort of a mindset that the higher risk patients are harder to include. But actually, at least from the studies we've done, almost the sicker the patient it is, the more complicated it is, the more they improve from these models, because otherwise they get nothing, right? So it's easier to show improvement. And so, for example, even though depression and anxiety are more common in women, men typically have a disparity in access to treatment. They don't disclose. But to have collaborative care for men, sometimes you need to have even in clinics or something, or for people, for working populations. Similarly, minorities, we've seen, John and I have both seen more responsiveness. Well, but then you need to have the language capability or the cultural adaptation or minority providers and so forth and so on to have the trust. So, you know, one can do a little bit more with either high users or high risk populations, but then you also need to make sure the resources are there and the thinking is there to tailor it. Anyway, I just wanted to give a cautionary note about evaluation, really thinking through. One approach is to benchmark. So whether you use AIM Center data or other, you know, national data for what might be expected for either level of implementation or quality indicators or outcomes or satisfaction, so that you can see, are you meeting a national benchmark, whether or not you're seeing improvement over time, and then you say, well, we selected these high performing practices anyway. Right, you see what I'm saying?
Yeah.
So.
No, and I think that's a great point. And I do want to clarify that my little pilot project with the 3 practices is just our little pilot. But in terms of integrating behavioral health, we've actually created a training that we're offering to all of our practices that are in our program across our 14 states. So, and the other thing that we're doing is not saying that, hey, you need to do this model versus this model. It's more, here are the multitude of models that are out there. Which one works best within your practice, within your resources, and what can we do to support you in providing and being able to help you implement that? So that's part of what we do for that as well.
So, Jerry, I think we heard that with respect to sharing information, some clarification over consent procedures, you know, getting faxes to be able to come back and forth from your consultant. But ask your question again, because we want to make sure we've gotten all the ideas.
Well, actually, directed to those of you who know California the best and the Medi-Cal population, because that's the context in which we're addressing the question. And that is, and I think we've actually heard kind of a list of policy changes that you'd like to see made. The inclusion of a wider range of professionals, MFTs, for example, the dropping of the one-day, two-visit type rule and so forth. And but are there others? That was the question.
This is your chance.
I believe there's been some discussion around changing some of the rules related to 42 CFR. I don't know that I'm an expert on it, but it has to do, I believe, with how much substance abuse information can be disclosed. So I believe there's been some discussion about taking another look at that and maybe making it a little easier to move that information around. That would be, I think, helpful.
Dan, a quick comment on that?
Just going back a step to medical school, have the medical schools embraced the idea of integration so that when a primary care physician graduates, he or she is already familiar with the concept and has embraced it, or how are the medical schools doing in this subject?
Who knows best?
They're doing a really poor job of it.
Thank you.
The departments of psychiatry are not training their psychiatrist residents to provide integrated care even. That's just starting to change. The APA is just starting to buy into the training needs there.
Still a long way to go. So medical students will go through graduate from medical school and then choose a residency. If you're going to be a primary care, say an internist, you'll go into an internal medicine residency and you'll be trained as a hospitalist. You know, 2/3 of your training will be in the hospital setting, and you'll get some outpatient exposure in the outpatient setting, and it'll depend on what you see in the outpatient setting. And so you may see behavioral, it depends on the setting that you're in. But I do think it's much better than when I went to medical school. When I finished during my residency, I didn't treat a single patient with an antidepressant because it wasn't part of what I did. And then when I went to work at the Valley, I had to learn really quick about that. So it's definitely improved, but long way to go.
It's changing, especially at the residency program level, and working within a Department of Family Medicine. I know that we have redesigned our entire residency curriculum to train family medicine residents to work in a co-located model with behavioral health professionals.
If there are any other policy suggestions you have, let us know, let Karen know, and we will capture them for our final report. Ken, was there another one right to mind?
Well, I was just going to, I mean, I know the performance-based incentives have been mentioned, and Jürgen Unitzer in Seattle did a paper on, showing that it increased.
Can we just thank Dr. Volrath for coming? She's got to run back to clinic. Thank you so much.
Showing that performance incentives for providers can help increase adoption of collaborative care and some suggestion of client outcome improvement. And, one of the questions, I think we need much more innovation around the structure of those incentives around a cluster of the core value, the core things that we've talked about, which include the population management. It's not that you screen the patient in front of you, but the population management values, the attention to diversity, improving outcomes for highly vulnerable populations. I mean, all of those things could be part of a formula, right? So it's really a matter of, especially as we move towards more performance and incentives, which of those values do you capture in that incentive? And you can't do everything, but you could do 2 or 3. So if the plans would innovate more and do pilots and so forth, we could learn a lot more, and the researchers are obviously, if we can get the funding for it, are trying to stimulate those things too.
Well, that's good advice for both public and private payers doing the evaluations. Okay, so first Chris, then Meg.
Thank you. So one of the barriers that we see, and I practice in mainly a commercial and senior population, is that behavioral health is carved out. Right. So our payments from the health plans does not include, in many cases, behavioral health care that is supposed to be taken care of by Anthem. So whenever our primary care doctors spend time doing it, we're actually doing something no one's paying us to do. We do it because we have to and want to, but and that seems to be a fairly pervasive model throughout the state. I know it's in the state of California. I don't know if that's also true in other states. But this seems to erect yet another barrier between the Chin North and the Chin South, and is not, doesn't keep with our understanding of how humans work as people we're trying to take care of. So any comments about that? And I think it's great to have innovative programs, but if it doesn't address, hey, wait a minute, if you're asking me to invest in putting a program together and time for my primary care doctors to spend on it, and you haven't addressed this carve-out problem, really, it's not going to fly.
Carve-outs? Go ahead.
I think that what the state tried to do is to include the mild to moderate mental health issues in the primary care, in the healthcare plans, so that we can deal with these issues to some extent. The problem is with the SMI, which I agree that this is a more complicated issue, but the state is working on that and is trying to do that. And I just want to say, and maybe it's a good opportunity to say that please, if you can read the 1115 waiver renewal proposal that we were just released in a few days ago, to CMS, that will be great, because there we have a lot of pieces that we are a lot of pieces that are related to behavioral health integration, and it's including, by the way, something that a little bit related to what you are saying, which is really trying to find way to coordinate the relationship between the mental health plans and the physical health plans and the managed care plans through incentives, through shared savings and between different providers, again, through incentives and through shared savings. So if you could look at it and give us some advice on what we are suggesting there, peer providers, we are suggesting there are different types of interventions to increase and to enhance behavioral health integration, that will be great.
And if you can make sure that Karen has that reference, we'll actually get that language out to folks. Have a look.
Excellent.
So have you been in Washington long enough to say how the carve-out approach is impacting care?
No, and it depends on how it's set up exactly. But I agree with the premise of the question. Carve-outs are not conducive for integrated care.
Okay, Colorado experience?
Down with carve-outs. I don't know what else to say.
Anthem says down with carve-outs too.
Okay.
We are trying to work and figure that problem out because we see that as a problem too, obviously. Because when you can't, the claims issue, I mean, it's a nightmare for the provider, for the patient, and for us. So I think we are trying to work on that. And I think the more studies and data that comes out that integrated care works better, then employers are going to be less likely to want to purchase their medical here and their behavioral health here. And they'll see that integrating there is also a key to this process.
Meg.
So this is a question about what order you put the spices in the stew. Okay, so we're talking about the secret sauce, and there are a lot of really, really helpful, very specific suggestions. And absent the ability to just basically redesign systems whole cloth, and I know that there are programs that try to help you do that, like through the program at University of Washington. But if you take a system that says, okay, I have to do it somewhat more incrementally, I'd like to hear some comments about which ingredients you want, sort of prioritize which ingredients you're going to put in first. Where are we going to get the most bang for our buck?
Thanks. Kim, do you have a comment, question?
This is a potential barrier for the parking lot because I don't think we can really solve it, but parallel to the reimbursement issue for the primary care clinician is the liability issue, especially as it relates to writing prescriptions for people you really haven't seen. And I think that sort of needs to be mentioned.
To answer this question, I mean, collaborative care is a bit of a kitchen sink. And most of the elements of collaborative care have been tested by themselves and found not to be effective. So it's kind of like a curry. You just put one sauce in and it doesn't taste very good.
This is much better than sports analogies. I'm glad you're going this direction.
I want to follow up on that. I agree with what John was saying. In fact, if you try to do it incrementally, what you'll find is that your depression care manager, behavioral health consultant, whatever you term that person, is so busy that they're never available to the primary care doc, and then the primary care doc in turn gets frustrated and stops thinking about behavioral health and stops making referrals. So it really doesn't work until you get to kind of a threshold staffing ratio that allows for that behavioral health consultant person to both take warm handoffs from the primary care person and provide some follow-up care to those who need it.
So, Kim, I'm not sure we actually responded to your question. It was about prescribing medications and liability. What was that again?
Well, a good analogy is diabetes. So, for example, I work with my diabetes nurse, and she takes care of the patients, and they're managed on diet, and then suddenly they fail diet, and now they need insulin, or they need glyburide or metformin. Okay, fine. You write that. I mean, by then you write that prescription, and you keep moving. I can imagine if I've got 150 patients as a primary care doc, someone coming to me and saying, okay, this patient needs, Zoloft. That might be somebody I'd want to see. So that would change the paradigm. But if what we're saying is that this is true care coordination, really I should write that prescription because the behavioral specialist has told me that that's what that patient needs. And is that how it works or not?
No.
And feedback there.
How does it work?
Yeah, so I mean, in that case, you would be managing the patient, and you'd have a care extender, basically. The part of it that they're more likely to be managing is the therapy, because that's going to be something you don't have the time for. Unless the specialist is, because it's very complicated, the psychiatrist is working directly. But in that case, if they're consulting, it's still going to be your prescription, and then you see the care. So it's not as separate as it may sound. It's really more like a care extender role. But in the AIM Center model, somewhat more of a professional level, nurse or something, and others have done somewhat different models.
All right. So yes, it's on you, Kim.
Right. But could I just say on the issue of carve-outs? I mean, I understand what some of the challenges are, but we've worked. I don't know, John, if the AIM Center probably also has worked with carve-outs and non-carve-outs and under various we have had also good. It depends on the relationship. It's like the doctor-patient relationship, the carve-out, rest of the plan relationship. So, for example, in New Mexico, the carve-out plan for the public sector Medicaid, gave the care managers, so they handled the care managers for the primary care practice. So I think it depends on what the commitment is. Maybe we should add commitment to that pot that we were putting together, and what the vision is, because we have so many diverse arrangements right now. We need to be able to take a model and fit it, like you were saying, to very different kind of situations.
I'm going to take a little slightly different turn and turn this slightly back around to the patient focus, at least I hope so. I come from the world of oncology, and particularly the scientific research part of it over 20 years, and we found one of the things that really is a big problem is terminology. And getting people on the same page, the same term, the same time, knowing what they're really talking about. I've heard a little bit collaboration and integration tossed around way too interchangeably here. And at the migraine meeting, my big comment at the end that got the guffaw was, that's your problem. You guys really need to straighten that out. You need to have the big powwow and get everybody on the same page about what it really means all the time. I get that CCM is a sort of we didn't really trademark that thing, but it's kind of perceived like that. It certainly was, I think, on our end, on the outside, on looking at this report. And then the comments that came back about that. The one that really gets me that I'd like you all to speak about, however, is behavioral health versus mental health, and really the one is behavioral health versus mental illness. Because this is a terminology that really matters to patients. I'm afraid it actually matters greatly to primary care docs that you're trying to get bought into this model, this idea. Because behavior is like, let's get them to quit smoking. And that was never considered a mental illness. And to a primary care, and from a primary care point of view, that's got an actual cause. We can find out nicotine's addictive. We can treat a nicotine addiction. And the behavior goes along with that, but it's really a behavior. Your parents used to give you a spanking for behavior. People with depression have spent a long damn time trying to get it bought, a lot of people anyway, have trying to get it, spent a long time trying to get it acknowledged that it's a mental illness, that they didn't really get a choice about having, and then we go along and change the term. I noticed that term actually changed in our report several times. And I really picked up on that last night. It really kind of bugged me. It really got in my craw, so I looked it up, and I find that there's actually quite a little school of thought out there in the internet world, at least, that behavioral health came from the payer side of things. It's a nicer way of putting things. It's not really mental illness. Now, I got a bigger question later that goes to something else, but particularly speaking of terminology, I'd appreciate a little comment about that.
Okay, who would like to start? I mean, we know that there's a lexicon, but then you have to memorize all the definitions. So how can we help clarify the work in this field? And what about the meaning of the sort of history-laden meaning of some of these words?
I guess I'll take a shot at it. So the way that I've always thought of it is behavioral health encompasses the substance abuse illnesses, challenges, disorders, as well as the mental health disorders. And I prefer always to say mental health as opposed to mental illness, just because it's a positive spin on it. So to me, behavioral health is a bigger term, with mental health being part of that.
Any other comments?
I mean, in my field, behavioral health refers to the combination of mental health and substance abuse issues. And we're not really talking about substance abuse issues here. So one concern I have about the framing of the report is that use of the term, because this is not broad enough to really, we've not talked about substance abuse at all. And if we were, the policy issues, the capacity issues, the training issues in primary care, we'd be having an entirely, cube whatever discussion we've been having. The definition, I just am looking at the 1948 World Health Organization. That was the year I was born. Mental health, and it's been like a shadow over my life. Mental health, a good shadow. Mental health is not just the absence of mental disorder, but a state of well-being in which every individual realizes his or his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to her or his community. So that's the kind of definition of mental health that my community accepts. And, and then the challenge is with whatever politics we have and whatever funding rules we have, we typically fund mental illness. There's almost no prevention mental health initiative in this country. I mean, there's some through SAMHSA, but if you talk about healthcare plans, what do you fund in the prevention area? Maybe suicide prevention, well, through the MHSA, right, in California. Anyway, I'll get off my,
No,
so.
those are very, very useful warnings and qualifications, and we'll make sure that the exclusions in our scope are very, very clear. Susan and then Maribel.
That's actually one of the issues I had reading through the executive summary before I came. I don't think of myself as having mental health issues, but I definitely have behavioral health issues. I cannot, in some cases, control what I eat, which has health implications. And to have behavioral health would be to have control over that. And I work with a therapist to help deal with that, which has very little to do with mental illness, which I take to be depression, things like that, which were also in it. So I was unclear coming here at the beginning what the extent that you were talking about. Was it something that affects me or something that I hope, at least at this point in my life, doesn't yet?
Very good words. Maribel.
So there is a consensus lexicon that was developed by ARC and led by Dr. C.J. Peak, who's brilliant. And it is long and it is complicated, and you're getting a glimpse as to why that is. That really breaks this down. And whether you adopt that lexicon or you adopt something that works better for you, like the World Health Organization definitions, kind of to tie into what you were saying, but also something I think that came from this side of the room around where do you start if you can't do it all? Start by getting your terminology really, really clear, because that will stomp you every single time. So before going into implementation, make sure that you understand what you're talking about in terms of the type of integration or collaboration that you're wanting to do, and make sure that everybody who's going to be working in that model also has the same understanding. That will go a long way to helping the implementation go a lot more smoothly.
So if we're talking about where do we start, we heard that from an evaluation perspective, you want to start with practices that are sort of bought in, they're committed. We heard that you want the infrastructure all developed before you start asking anybody any questions. But is it really an all or none big bang thing? Is there a way to build up your program? Can you start just with, patients and work out your workflow? Can you start with one condition, depression, and one survey? How do you actually, when you're helping people implement and you're trying to replicate these things, do you ask them to do it all?
No. I'm glad you asked that, because it made me think about the question differently that Meg asked earlier. So if I was going to do this incrementally, I would just keep it to a certain number of providers and add a behavioral health person for that particular group, knowing full well that I'm favoring the patients in that panel, and eventually, and that's not really fair, and eventually, hopefully, I can do it for everybody. But that's the way I would do it. You just do the model smaller.
And you start with somebody who's a leader in the clinic,
right,
and can pull other people along.
Right, your champion provider, yeah.
Okay.
Well, I mentioned earlier that I was co-led this American Red Cross. So imagine the situation. I could show you pictures from that, where most of the clinics are destroyed. So you don't have a choice of either starting small or relying on the providers. And but we took this model, this very rigorous model that John described, and trained any willing person, basically. And, there were doctors there, and there were counselors there, and there were ministers there, and there was the neighborhood watch leader, and, anybody that was available. Yes, things were incremental, but the point is there are situations where you go with what you can, but you still have a model in mind. I think that's the part of it, in some respects, that John and I are trying to emphasize the most. What you do with it, what the goals are, whether how much is about disparities, but there is a model in mind that people are holding their feet to the extent that they can, and you can only do what you can do, But the nice thing about not every mental illness, I will use that word, but with depression, there is a lot you can do with doing, close to the right thing. Trauma-informed stuff, that's a little different because of the exposure therapies, harder to do, takes, it's got risks with it and all of that. But there's a lot of good that can be done trying to get to the gold standard. But you have to have some model in mind.
So from what you've heard, are you convinced that you should be taking this and becoming an advocate within your own health system, your own clinic, your own community, or do you need to hear something else? And I'll ask all of our panel members.
I just have first a pragmatic question to ask for DHCS. So I haven't read the 1115 waiver all that closely. What we have heard today, is it possible then when that waiver gets approved this fall that all these 70% of Californians on Medi-Cal are in managed care plans, that there will be funds and support available to help them set up the kinds of structures we've heard? Do we have hope here?
I will say yes. I don't know what will CMS embrace and agree to do you hear me? Yeah. To accept, but in the proposal, and really, I'm really encouraging you to read it and to give us your comments. You will have a place to provide comments to that. You will see that behavioral health integration is across the board. It's not only one project or two projects. It's really across the board. So there are many things statewide, and I will talk about it. And also a project that we can try in specific regions or specific, and we are talking about a whole person care in specific places that counties will take on, and et cetera. So, and it's a workforce, it's financing. We're talking about $15 to $20 billion that we want in the waiver in general. But as I said, very critical piece of it is behavioral health integration. DSRIP is included there, and in the DSRIP piece, we have a lot of integration, not only behavioral health and physical health, but also the different, also long-term care, etc. We also have the health home, which is aside, and we are pursuing it as well, and this is supposed to be launched in January 1st, 2016. So this is talking about the high utilizers, that we are trying to find solutions for that. We are trying to find housing solutions through the 1115 waiver. So there are many pieces there that are, I prepared a lot of things to say about that, but there are many pieces. And I just want to say that the pieces are also related to each other, because in November 10th, what we did, we had a stakeholder meeting that were all experts in integration, and this guy was there as well, and other people, including from Washington and other country experts on integration, and they provided with building blocks for integration for California. And there were people from the managed care plan, the mental health plans, the counties, the different pieces of the healthcare industry, including mental health and substance use, and trying to come up with this piece. This piece was written, and we had a summary, and this went into the 1115 waiver work group that worked on the 1115 waiver, and also many of the experts that were in this meeting went to that. And so that's what I want to say, that it's also a cohesive piece of work, but we will see what happens.
So There is hope.
In Washington State, I mean, there is hope. In Washington State, the Medicaid plan that's run by the FQHCs reimburses for care managers. Virtually all the FQHCs have care managers running the collaborative care model with psychiatric support from the Department of Psychiatry at University of Washington. All the psych residents go through a rotation on that training. So yeah, it can be done.
Did you know about that clinic at Stanford, by the way?
I did know about that, and actually it's too bad she had to go because I wanted to know how they specifically were being evaluated by the payer and what is being expected of them. And in terms of your question about advocacy, I'd say yes, with the idea that we would want to I'd hopefully show that we could see similar outcomes to those seen in the clinical trials. And so I'm a big fan of randomized rollouts, if you will, where we can do a more rigorous evaluation as we roll something out. But the question I would have is what metrics should I be, say I'm the payer now, what metrics should I be looking at to decide whether this is something good and continue on as it is, or does it need to be shaken up? And I'm just curious how many of the payers right now are in the back of their minds thinking, okay, we're going to see cost savings here eventually, and that's the reason why we're funding it. I hope that's not the case, but so I'd be curious about what the metrics should be.
So one of the advantages of doing measurement-based care, using PHQ-9 scores to drive clinical decision-making, is that you then end up with aggregate PHQ-9 scores. And so clinics can tell you 20% of our patients have responding, 80% are responding, and so you can use that as a metric. You shouldn't penalize clinics that are treating higher risk patients that are less likely to respond, because there's patient demographics or clinical characteristics drive response rates. But you should either, the clinic should either show that the patients are responding or that they have changed the treatment of the patient who hasn't responded. I think that's the metrics to use.
So I think we've heard that at baseline there should be some sort of adjustment for patient and clinic performance characteristics. But in terms of outcomes, what is Anthem expecting to see?
This is one of those questions that I'm still trying to answer, because when it comes to, I mean, one of the limitations that we have as a payer is we're claims-based. And so all of our metrics are claims-based, and there is no claim for a PHQ-9. And we definitely don't have access to what the score was. So unfortunately, when it comes to quality, like right now, I actually really dislike the metric that we currently have in our, in some of our program is, you know, the start of medication for depression. I'm like, well, that's only a small amount of the population who, one, is depressed, or two, really needs medication. So we're missing, and it's just not a good measure. So I'm open to ideas because I don't know. One of the things we are going to do is look at cost, because that's one of the things we can do, obviously. But I want to look at cost from the perspective of what's the total cost of care versus what's the cost of behavioral health care. And then I also want to separate out health and behavior codes, because that's getting to that population of patients who, you know, like Susan, I don't have a mental illness, but I have a behavioral issue that somebody is supporting me with, and there's a claim for it. So I want to be able to sort of divide it up that way. And that's my goal. If I can get a report built in our system, that's what I'm going to try to do with our project. But if others have ideas for metrics, I am all ears, because I'm trying to always figure that out.
Okay, we'll be going around, but Michael's got a comment.
At UCLA, as part of a DSRIP-funded primary care innovation project that was led by Molly Coy, part of it was embedding behavioral health. There was also pharmacy, and there was a navigation model. They called them something else besides navigators. The things we measured, so we looked at all of it. So it sounds a lot like the Stanford Clinic, what we did. Although I should say that the psychiatric piece of the model used psychiatrists, and we basically burned them out. So we really need to transform that into more of a University of Washington model, and we're working on that now. Ken knows a lot more about that than I do. But the outcomes are the ones you look at: readmissions, ER visits, and then and they were all winners, huge huge changes in both of those things. They did look also at hemoglobin A1C in those that were appropriate. But the big winner was physician satisfaction. You know, the triple aim +1 provider experience. Do we forget about the provider? And that was a big hit, having both pharmacy and the behavioral health support in the clinic.
Would you add any other outcomes that you would suggest?
Well, and I assume along one of those was probably the patient experience of care, which is a big one.
Okay, thanks.
So HEDIS has proposed new measures for depression quality of care, and they are using a PHQ-9 to monitor depression symptoms, and based on those scores, the depression remission response and treatment adjustment. So that's what HEDIS is proposing to use. That was, I think, closed for public comment in March.
And those things matter. We will be going all the way around, and we haven't forgotten that Bob has a big question that we're looking forward to.
It's not all that big necessarily, but one of the things that Michael keyed on, and when you asked Paul, there's a at least marginally roughly parallel model from the cancer world. It's huge and doesn't really go exactly, but concept-wise, it's called the Comprehensive Cancer Center. We've got a bunch of those around. They're very big, but the reality of that is most patients still go to their corner oncologist for treatment. They get their surgery at their local hospital. They get referred to a radiologist who doesn't do anything else except cancer. They'll never see again because they can't for that particular thing. It's a weird kind of thing, but in a comprehensive cancer center, it's supposedly a different experience. Now, that is actually wildly different across the board, much more so than they would like you to really know. But the deal here that I'd really like to get to actually is the doc experience that we're talking about, the office experience, and the patient experience that you asked Paul about. Because by and large, patients and many of the docs actually feel better in that comprehensive cancer center. And the reason they feel better is because it's a more holistic thing. It comes across better. It may actually not be any easier to do. Many patients have to go to real extremes to travel to one of these comprehensive cancer centers. And they go back and back and back frequently. But it feels better. And you talk about a mushy report, a mushy set of data that we were dealing with this report, and we've tossed that around amongst ourselves. A really fuzzy measurement is exactly that kind of stuff. You know, there's no instrument that I'm aware of that really gets to that. But there's something there that really matters. If you get, my question actually goes kind of to that. What is the real buy-in of the places where you implement these models? I mean, the oncologist office used to be the single most depressing thing that a patient ever saw, and it's just not good. It doesn't bode for a good experience. It doesn't bode for a good outcome. Does the environment in these kind of models that the patient and the staff experience really change and become more enjoyable, if nothing else?
Is there more joy in this work?
I definitely think there is, although I don't have any evidence to provide you for that says that. But I know that our docs, a lot of them initially were somewhat hesitant to want to take this on and have gone from being hesitant but willing to wholehearted advocates just by virtue of doing the work and seeing how much easier it is for them to be able to give this person to somebody who has more expertise than they do in treating depression, and then see their patient get better, and see also, although we didn't see good evidence for it today, see also that these folks, their physical health outcomes improve as well. Even though, like I said, we didn't really necessarily prove that today. So the doc experience, I think I agree with you, it's huge. To me, it's the engine that makes this go. The clinics I work with the docs tend to be the ones that make or break things. If you get the docs behind something, it goes. And the docs have, like I said, they've gotten behind it over time.
Thanks for pointing that out, Bob. Ken?
You just reminded me of something else that might be worth pointing out, which is for people who are not used to taking care of mental health issues, this can be stressful. And I mean, it's nice to be for the docs to have it offloaded from them somewhat. But care managers, case managers, whatever you want to call them, that have some mental health background, and gravitate towards that, it works really well. When we took lipid managers and retooled them, they needed a lot of support. And what we ended up doing, this came out of our New Orleans work, because there all of the people we were training themselves had lost their homes and so forth. So we developed a strong focus on self-care of the providers and the trainers and the collaborative care staff, including doing their training by having them receive, the therapy or whatever. So I think in under-resourced communities especially, since we're talking about Medicaid as our model today, a lot of the providers also will be from the same community where they're facing, similar stressors and so on. So something else to keep in mind when you're exploring these models in practices is some attention to the well-being of the staff that are being trained, and especially as they gain more and more direct exposure to people going through stressful experiences themselves, and being prepared to support them under some model might be worth considering.
Training is a huge component.
Really good. So again, we're going around to our panel members asking if what they've heard would change them into an advocate, if they weren't already, for this BHI approach. And if not, what would they need to hear?
So as I mentioned earlier, I think there's an argument to be made for in future discussions, or maybe in the panel when it gets to the East Coast, of splitting out the disparities section, and maybe as a separate question, with its significant attention, thorough analysis. It's clear that and I also want to say I really enjoyed the phrasing in the report that Jeff and Dan wrote about how reimbursement for behavioral health and primary care is low. So in that context, $2 per member per month seems very reasonable. And also the IOM concluded 20 years ago, right, that separate payment structures for behavioral health and primary care is just ridiculous and detrimental to patients. And why are we still stuck in the same, right? And the low-hanging fruit here may be, changing the FQHC, same-day restriction. Let's see. Oh, and finally, CJ Peak, who was on our call, with the expert call before this meeting, really encouraged systems to track and outcomes, particularly long-term outcomes, because, as he noted, University of Washington was really set up to do this from the ground up, and that may have been why a collaborative care model took off and is, the one that everybody's emulated. But it may well be that there are other innovative models that are working out there we just don't know about because we don't have the evidence.
Kim, did you want to ask any other questions? Are you convinced? Are you going to bring this home to Cedars?
I was a proponent all along with my MPH, health service, MCH background. I will say as a clinician, though, there is the challenge. Like, there are two, open Epic charts now because I need to make the referral. And these are people with insurance, and having the right resources to refer them to is still a challenge.
That's a problem. Jeff?
Well, I'm a little bit of mixed mind here, because if I actually screen for depression, then I actually have to fill out the PHQ-9, and then I actually have to make sure they get plugged in for their appointment. And so, there's a little bit of a personal thing. Now, actually, we see a lot of, it's expanding out a little bit. I think after this discussion, a lot of what I take care of is automatically got a high rate of depression, because I see, Parkinson's disease and multiple sclerosis, and their brain diseases with, altered biochemistry that leads to depression. And we sort of don't really address that, other than we sort of ask about it and kind of try to get them off to somewhere. I think it might, I'm actually going to be thinking a lot more about adding those screens into it. Not so I get to fill out more forms, but I get them to somebody that can take care of them a little bit more efficiently. Because I think that the idea is, it isn't a separate thing. In our institution, it's more integrated, I know, than a lot. But I think we can do a better job of thinking about it up front, as long as I don't have to fill out more paperwork.
Well, it's not only older cardiologists who are the good physicians, it can be some really good neurologists too. So,
Can I make a comment on the PHQ-9? The patients really find it validating. Often when you're depressed, you're kind of blaming yourself that you can't pull yourself up by your bootstraps. When they fill out the PHQ-9, they go, oh, this is a real disorder. And it facilitates communication with their provider. So patients like it.
And you don't have to fill it out.
Well, that's the key. I mean, that's what we have right now. I do, so I got to figure that. That's the first step.
Yeah, as a retired oncologist, I share Jeff's view of the world. I dealt with it on a case-by-case basis and referred a rare patient out. But I think the current system's broken and needs a reassessment.
now, Dan, you were talking about your friends who are psychiatrists. Are you
Yes.
going to go tell them that they need to change?
No, they say integration good, carve out bad. So I mean, that's the message. But my response to this is, I'm reminded of the famous Francis Peabody quote, and that is, good care of the patient requires caring about the patient. And patient care is both physical and mental. So we're talking about systems of care. And if the entree to the American healthcare delivery system is through the primary care physician, then it's axiomatic that we should have integration of behavioral care at that entry point into our system. So we've spent a whole day looking for evidence that integration is a good thing. I think we should accept that as an axiom. The mathematician would say without proof. And what the exercise should have been is, let's look at the evidence for the best way to do this. So I guess I'm on board.
Come around here. So you have influence in your large healthcare system. What do you think?
Well, I think, as I mentioned before, the carve-out issue is one that usual care for our system means that either an overloaded primary care is trying to manage this, or the patient goes off into the void. Anything would be better than that. And I think that this is an interesting proposal where it would be important to our system is knowing specifically more about the senior population, because that is, the economics are different than for the commercial population, and certainly that population has higher morbidity, both mental and physical. So that would be a key piece for me. The other key piece for me is really, what does this do for overall health care costs? Because I certainly can think of myriad examples of patients who had, headaches and went to see and got an MRI, and, palpitations and got Holters and who knows what all else. And, around, and, they got scoped and they got this and they got that. No, I must have cancer. So, CT's up and down. And then they get to someone who wants to be more behavioral health based. Sometimes it was me, sometimes it was one of my colleagues. And we realize you're depressed or anxious, and all that stops. So I know that the cost of care goes down, but I need more actual evidence of that to justify the upfront cost of hiring, 40 case managers for, what was it, 200,000 patients. So that for me, it's going to be 120 case managers. So we need some more kind of brass tacks to get big systems like mine, who are going to, no mission, no margin, no mission. And we're going to hear that more and more. We really need that kind of analysis to be able to drive this forward.
You might look at Andy Bindman's March 17th JAMA commentary.
Okay.
Andy is from UCSF, and there's a commentary on how January 1st Medicare reimbursement of care management changed, and what the per member, you may know, I'm sure you know that like the back of your hand, but anyway.
Yeah, we actually costed that out, and for us, it's actually not going to be.
Oh, I see. Okay. Well,
cost-effective,
I tried.
unfortunately.
Meg.
So I might echo some of what Christine said, and as far as penciling out the CCM codes, that's what I mentioned this earlier, the $49 per month. We'll try to capture it, but it's still probably, it's not going to, it's part of the conversation, but it's not potentially a game changer. So the things that, there's what we've been doing, and then there's where we need to go. As I mentioned earlier, we've had some crises in our community that have suicide cluster in 2009, another one we are in the middle of right now among teens. And the tiny silver lining in that is that it has changed the conversation. I mean, a horrific reason, but has changed the conversation. So what we've been doing are working with Adolescent Behavioral Health Project, which we privately funded through our own folk, including doctors and some community members and so on, to actually improve, starting with essentially incremental parts of the chronic care model and but we are hampered by the same challenges around having carve-out networks so we can identify, but actually linking people to services is still an issue, but it is one aspect of it. Taking it up another notch, we've been working in a community of Santa Cruz, which itself has horrific access to mental health. So there is a plan now to start essentially from scratch. The good news is there isn't anything to have to break and remake. There's nothing there. So we're starting from scratch again with internal money to create a system that includes these care models. We've been working in the community, talking about trying to access the community. I work now with Caltrain, the city, the school district. I have people on my email list I never thought I would be talking to because we're trying to figure out how we can work as a community to improve mental health services. And so it's very interesting to be working in a whole different mindset about what we do to improve care. And then just yesterday had a meeting where, for better or worse, when you take the various crazy bits and pieces of where there might be a little bit of money, including the CCM codes, and thinking about there are other codes that Medicare may pay for, that we realize that we ought to take all that as another part of the fire that incentivizes us to just say we have to do the right thing. So on one hand, I'm optimistic that we're going to be making some major changes, but that ROI is still going to be the question of the day. And a lot of that is around some of these uncertainties regarding staffing. And the third part, again, is partnering with health plans. And, we talk about whether there's a carve-out or carve-in, but that's a little bit of a shorthand. The challenge there is finding ready access to high-quality providers who can provide the care for the patient who may have a diverse background, and how we link patients. And whether that's actually carved in or out, it's not really the carve-out per se. It's the access to the right people at the right time. And whether it was carved out or not, frankly, we would have a hell of a time actually providing that. So that's I think the term carve-out is a little too glib for us in terms of saying how do we partner to make sure that we can really get patients to the care, whether it's hip to hip or whether for other legitimate reasons it's off-site, whether it's telephonic or just wherever they live or work. So I don't think we've solved that, and I don't think we're going to solve it simply by carving back in. So those are the challenges we're seeing.
Thank you. Bob.
As usual, at the end of one of these meetings, and it's interesting. I'm trying not to get depressed at the state of our unhealth system, but I do find it rather encouraging that so many of us, and even the ICER people, were not exactly overly thrilled with the product that we were working with here. But I think it was actually better than they think it was. I found it to be quite interesting. I find the meetings to actually be getting better too. Just for what that's worth to everybody. I appreciate the robust discussion. I really actually do. It's quite intriguing to watch this thing. I have no particular bone to pick with and horse in this race the way Meg and Christine, several others here do. So I think that's one of the things that I come away with this. I appreciate these kind of discussions. I think we actually ought to have more of them. I've always been a big proponent of everybody come to the table and put all your cards on the table kind of thing. As usual, we don't have all of the players in the game here, and we could do a better job than that. I will try and close this little diatribe out with, I do wish you guys luck with the next at your next at bat with this thing. So,
thanks, Doug.
So, I'm glad. My bias is this should have worked. It ought to work. And I was glad to see that there was some evidence to support my bias, but I was a little disappointed, actually, at the level of the evidence. And I guess I would argue that it's our obligation, and those of you that are interested in this area, to continue to really pursue high quality, mostly randomized trials to show that we can improve upon the models that are currently used. And I think we can do probably even better, more efficiently, and more effectively. And I don't think that something like this, just because it ought to work, ought to get a pass, and we ought to say, well, you know, it should work. I really think that, as we told the surgeons many times, you have to do sham studies if you really want us to believe that it's going to work, and they grumbled terribly. But I would argue that we should hold the same high level of evidence for everything that we do, even though it's expensive. But again, PCORI's got a lot of money, and this would be a great topic for PCORI, actually.
And Jerry.
Well, it's interesting to be last. And try to say something different. I don't really think I have that, but I could try to say it with feeling. So just a couple of things to pick up the feeling. I want to agree with Alex that I think that we should address the questions of disparity, and for me, the questions of equity as a priority in the report. I've learned some things today that I think could be elevated in terms of their visibility here. There's, you know, you may have what looks like a very small effect when you distribute it over a big population, but it may be a very important effect for certain segments of that population who deserve a fair shake. And so I just want to say that clearly. Seems like there's some very obvious policy changes. Given how obvious they are, and yet how long they've been obvious, I don't know whether I want to join Marge in being hopeful or not hopeful about that. But you know, things like the same-day rule, expanding the list of professionals. I saw an Intermountain study that showed you could get much more cost-effective use of some professionals like MFTs and get a better deal, so to speak, for the dollars. So I hope that the report is effective in bringing about some of those changes here in California and elsewhere. Finally, I just want to echo what was just said by Doug and probably others. This group for many years has prided itself in a pretty hard-headed look at the evidence. And sometimes when we go through this and we see a certain amount of, some person put it, squishiness, a certain dis-ease that we have with the confidence we have in the numbers. I hope that what we can also be then through this process is good stewards of the best questions. There are some good questions here that really need to be taken care of, and I think that is a legitimate role for this panel.
Jerry, that's a great comment, and it actually goes to the very, very last thing I'll be asking you before we can thank our roundtable participants, which is that this was not a drug or device, things that we are pretty confident in our ability to pursue and evaluate and discuss. What were your reflections on how we approached this health system delivery change?
So I've been dying to say this all day. You know, Jeff was right. The effect sizes, you know, 0.2, 0.5, 0.8 are small, big, large. You know, whether they're small, big, medium, or large, it depends on the context. And usually those adjectives are about treatments, drugs, and devices. In this case, this isn't a treatment. This is a model of care that engages people in evidence-based treatment. So it's kind of like 3M. They don't make the product, they make the product better. That's what collaborative care does. So you have to think about the small effect size in that sense, because this is not a treatment. This is just a way to get people the treatment.
Great perspective.
I was just going to say, I think the process that we did here was as good as we could do. But I also wanted to say, you know, this is the human condition we're trying to change. And it's the most complex of all the human, just as we know that medical care advancements have nothing to do with longevity. It all has to do with public health. Well, this is, you know, we've got the elements of our population that are the most challenging. And so expecting to see dramatic improvements based on new and better and clever and resourceful and effective ways of delivering care, is great, but I think we should, I don't want to say lower our expectations, but be more cognitive of what a big, steep hill this is. That's all.
Not a drug or device, a health system intervention?
We worship at the altar of randomization, blinding, consistency in our studies, and these don't always work when you start looking at systems of healthcare delivery. Very frustrating. And so rather than to sort of dismiss everything, I think we need to grow. And I'm interested in, I don't know what big data means. I keep looking for the answers in big data, and maybe we'll find out. Or some of the electronic medical records that are accumulating all these data. How do we as methodologists look at that? I guess we don't want to accept expert opinion, but in a way we kind of turn to the experts and say, well, is this a good system? And they say, yeah, it's pretty good. It's better than the others. So, and we're very opposed to that because, our clinical guidelines have often been pronouncements by, what was the term, eminence?
Eminence-based
medicine.
medicine.
Eminence-based medicine. And I think we all bristle when we hear that. But I think we need to grow. I know Doug is scowling at me now, but I think we need to discover new approaches to evidence when we take on systems like this. I don't know what's going to happen, but that's my hope.
I'm struck by the contrast in the topic from the last meeting in this room and this meeting in this room. The last meeting, for those of you who weren't here, was about hepatitis C treatment, in which we were considering treating at enormous expense many people who were asymptomatic and would never actually experience a benefit because they were never going to get sick from the illness, but yet we had a cure. In this situation, we have a widespread problem, and we maybe can help a proportion of those people with a new model, which means many, many symptomatic people who can be benefited at modest expense. That's all I got to say.
That's a good one. Anybody else?
Well, I just want to thank CTAF for taking this on. I think I might have been the one who proposed this topic, and I just really appreciate taking on the challenge because I think that it's a good exercise. It's a huge, important issue for us, and the fact that we're exposing the flaws in the data, the evidence, how we synthesize that information and how we apply it is the real world. And I just think it's important, and how it bodes for the future for topics that are taken on. Hopefully we learn about how we might apply this in the future for things that are not as cut and dried as drug A versus drug B, cost this versus cost that.
Reflections.
Which are you, Dan 2 now?
No, yeah, Dan too.
You're Dan 2,
And
right? Okay, I just want to make that. I just want to make that straight.
Yeah.
Just for anybody else out there that cares, Dan actually coming slightly off of the RCT tree is really quite shocking to me. It's quite a thing that I really appreciate. And I haven't gotten through the CJ Peak on our expert call referred to this particular paper, the 5 R's. An emerging bold standard for conducting relevant research in a changing world. I haven't actually gotten all the way through the damn thing yet. But it is not quite yeah, well, that's the deal, okay? I come from a world where RCTs really are the gold standard, and there is no other way around that. I used to be as big an RCT true believer, randomized controlled clinical trial, for anybody that doesn't know. But we are in a world that's changing far too fast, and too many things really are too fuzzy to wait so damn long for answers that aren't clear when we get them because the question wasn't that good. And it's largely because things changed during that time while that trial was supposedly being designed and conducted. And we do have to come up with some kind of different models. I really don't want to give up what Doug alluded to. I don't want to give it up at all. I'll fight real hard for that. If there is a way that we can do an RCT, and we should have done an RCT, then we, by God, should have actually have it right here on the page. But we do got to come into the real world a little bit here. And some of it in our world really is in big data. And that's a place where people have wanted to look for a long damn time. But collecting that data requires observational studies that hardly anybody actually has really wanted to take on in the past. But there is something there.
Thanks. Quick
So,
response.
quick response, Bob. I read both of Pete's papers, and I was hoping to find the answer. I didn't understand a word he said. So tell me, you know.
We are going to have to wrap up very quickly.
I just want to dovetail on Christina's comment that I agree. Like, we spent all that time talking about a drug that was $1,000 a day, and now we're talking about something that's not even the cost of a cup of Starbucks. And it really does make you wonder.
Good points. Finally, reflections on this? Jerry, you're so good at the final reflection, though. All right. With that, please let us thank all of our roundtable participants who were very generous with their time and insight and expertise. Thank you very, very much for coming. As always, thanks to our panel, and thanks to our staff. And you are free.